Funding provided by the League of Women Voters Project Fund.
With that, we'll move on to Proposition 106, a brief introduction to access to medical aid in dying medication. An initiated proposition adding a new section to Article 48, Title 25 of the Colorado Revised Statutes to allow an adult resident of Colorado to request and receive from a physician a prescription for a medical aid in dying medication for self-administration. Major provisions: allows an individual who is a Colorado resident, 18 years old, mentally competent, and who is diagnosed with a terminal illness and has a prognosis of 6 months or less to live, to request an aid in dying medication for self-administration from the attending physician. Establishes requirements for physicians administering aid in dying medication. Establishes criminal penalties for causing an individual's death by forgery, coercion, undue influence, or destroying or hiding a cancellation of requests for aid in dying medication. Establishes rules for documentation and death certificates. And establishes that medication for medical aid in dying shall not affect a life, health, or accident policy or annuity.
Good evening, ladies and gentlemen. My name is Ken Stubler. I'm speaking this evening on behalf of Yes on 106. We'll get into all of those details here in a little bit. A little bit about me. I've spent 40 plus years in the healthcare industry. I have been administrator in hospitals, long-term care facilities. I've spent a number of years in public health as well. I've taught at the college and university level and spent about 10 years of my professional life in working with hospitals and nursing homes to develop medical ethics committees. Those committees that work with families and patients in resolving biomedical ethics issues. So it's been a long time since we've worked very, very hard to get this particular proposal out in front of the public in the form of a proposition, and I look forward here in the next few minutes to share my thoughts.
My name is Vincent Patarino. I'm an assistant professor of history here on the CMU campus. I'm an early modern historian, which means that I study a lot of both political history, religious history, cultural history. I am the director of the Holocaust Awareness Program here on campus, which has been running for about 14 years. I am also the Western Slope coordinator for National History Day in Colorado. I come to this issue talking about the con position on Proposition 106 from a couple different positions. I am an independent voter, and so I'm unaffiliated. And I came to the position originally actually from a positive position, and then as I studied it more, decided that I had positions on the other side. I'm also a member of one of the local Catholic churches, Immaculate Heart of Mary, and in some ways I bring part of that position to the arguments that I'll be making. Thank you very much for having us here tonight.
Ken Stubler is representing the proponents of Proposition 106. Mr. Stubler, would you like to make your 6-minute presentation?
Yes, thank you very much. As I mentioned in my opening remarks, I have been a member of a number of medical ethics committees in our state. I have been a participant with patients and their families in these agonizing and gut-wrenching decisions concerning end-of-life care. And I have come to the conclusion that every individual deserves the right to make their own decisions concerning medical care, even if that choice differs from one that we would make. Before we talk a little bit about aid in dying, I want to talk about what aid in dying is not. It is not euthanasia. Euthanasia is administered by a third-party medical professional and usually by lethal injection. It is the medical professional and not the patient who is in control of the person's death. Aid in dying is not suicide. Suicide is choosing death over life, and often that individual experiences great depression. If treated, this person can live a full and happy life. A terminally ill person is actively dying, so only has the choice of one form of death over another. Terminally ill people that I have spoken with related to this particular law take great offense when the word assisted suicide is used. These people are not choosing suicide. Many wish to live, but unfortunately, nature has provided them no opportunity to continue their life. As mentioned, the proposed law allows a mentally capable adult resident, and I emphasize a mentally capable adult resident, who is diagnosed with an illness likely to cause death within 6 months, an option of requesting life-ending medication to be self-administered. And again, that's an important element of this law, to be self-administered if suffering becomes unbearable. In this law, the person must be an adult, as we mentioned, 18 years of age. They must be a legal resident of Colorado. They're diagnosed with a terminal illness likely to cause death within a 6-month period. The diagnosis must be confirmed by the individual's physician and a consulting physician. To be eligible, a person must be mentally capable of making that informed decision. Any concerns about coercion or the ability to make an informed decision requires a professional mental health evaluation. The person must make 2 oral requests separated by a minimum 15-day waiting period. Those oral requests, again, are made to the individual's private physician. A 3rd written request, signed by 2 witnesses, is also required. At least 1 witness cannot be related by blood, marriage, adoption, civil union, nor stand to gain financially from the death. At least 1 witness cannot be an employee of the healthcare facility where the person is residing. The person's attending physician cannot be a witness. There must also be a private physician-patient consultation with no 3rd party present during that conversation. The patient must be counseled on all feasible treatment options, including comfort care, palliative care, hospice, and pain care. The person can rescind their request at any time. The person must be able to self-administer the medication, and anyone who alters, destroys, conceals, or forges a person's request commits a felony. Provided all procedures are followed, doctors, pharmacists, and healthcare providers are immune from civil and criminal liability. Individuals are also informed of the importance of safekeeping and disposal of any unused medication. If a doctor, pharmacist, or other healthcare provider is opposed to aid and dying, they do not have to participate with the individual. The cause of death is listed as the underlying illness or disease. Insurance companies cannot deny payment on an annuity, health insurance, or life insurance policy. Most people are able to have their pain and symptoms adequately managed, as we talked about, through hospice or palliative care, but there will always be those for which the best medicine and technology still unable to relieve their suffering. This proposed law is based on Oregon's law. Oregon's law has been in effect since 1998. It is rarely used, but patients simply knowing there's an option brings comfort to many. During the 18 years that Oregon law has been in effect, there's not been a single proven case of abuse. Few people use the law compared to deaths from all other causes. Deaths under this represent less than 0.4%. In terms of support, generally physicians are supportive. 54% of physicians in a recent survey agreed. And interestingly enough, among adults in Colorado who regularly attend church, 62% of those people believe that the law is valid.
Thank you, Mr. Stubler. Appreciate it.
The way I'm going to present this is that there are basically two central lines of argument against Proposition 106. The first entails a number of cultural, legal, medical, and moral issues about giving terminal patients the legal right to end their lives. And the second is that this is a flawed measure in both construction and intent. It is not as rigorous as the Oregon aid in dying law. And I think that this should cause a person who generally supports the concept of assisted suicide to at least look twice at this proposition. If we look at the first set of cultural, legal, medical, moral issues, physicians, while greatly respected for their talents and their expertise, are not always right. They do make mistakes. Terminal prognoses are sometimes wrong. Many of us know of cases where individuals outlive their diagnosis, sometimes by months or even years. In addition, most doctors would admit that there are factors that cannot be quantified, such as a patient's disposition and positive nature that plays a role in recovery. Assisted suicide leads people to stop looking for treatment options, causing them to lose out perhaps on months or years with the people that they love and those who love them. Second, the American Medical Association has said, quote, physician-assisted suicide is fundamentally incompatible with the physician's role as a healer. It changes the relationship between the physician, whose first rule, do no harm, with the patient. Instead of caring for the patient, they negotiate the patient's burden to the family and the state. Third, we live in a capitalistic, market-driven society. If assisted suicide is made legal, it immediately becomes just another treatment, and most significantly, the cheapest form of treatment. As a result of market forces, death takes first place in a menu of options proposed to the bravely ill. Now, this is obviously an anecdotal example, but in Oregon, where the law has been in place since the end of the 1990s, Barbara Wagner was denied coverage for cancer treatment, but received a letter from the Oregon Health Plan that stated it would cover assisted suicide. 4, depression is a leading cause of teenage and adult suicide in the country and in Colorado. We all know what it means to go through periods of depression. Some struggle with depression or anxiety for much of their lives. Many terminally ill patients struggle with fear and depression, which can color decision-making. Terminally ill people are vulnerable and sometimes susceptible to pressures both subtle and overt, including self-imposed guilt over burdening the family or being made to feel guilty about using family resources. Some people with disabilities have experienced prejudicial attitudes from the able-bodied who assume that they would, quote, rather be dead than disabled. People adjusting to life with serious illness or disability can be depressed and emotionally vulnerable, and left without protection, they may be branded an economic liability. In the second set of comments, I want to talk about some of the particular failures of this proposition. The measure fails to include reporting requirements that are in place in the Oregon law. There is no way to report or track Colorado's program. Second, the measure fails to protect one from explicit or implicit family pressure to commit suicide, ameliorate fears about being a burden. Third, the measure is not internally consistent with Colorado law in regards to the age of consent. So one can vote at the age of 18. You can take your own life in that sense, but you can't drink. The diagnosis of terminal illness can be made by 2 physicians. However, the proposition's language is inexact. The certifying or consulting physicians could be of any sort. Should it be all right for a podiatrist, for example, to sign off on death because the patient is terminal with stomach cancer? And who determines the patient's mental capacity to make that decision? According to 106, it is the certifying and or consulting physicians and not a trained mental health professional. The dying medication must be self-administered. There is no type of medical professional of any type to be present. This is especially significant because barbiturates, which are used in Oregon and Washington, do not always ensure a peaceful death. Finally, the death certificate will be required to list the terminal illness as the cause of death and not the self-death as was the case. It comes down to this: if we are too squeamish to report the truth, what does it say about our societal comfort about the concept of assisted suicide? Thank you, and I'll be happy to answer questions.
Wonderful, because we have two questions for Prop 106. The questions aren't specified to either speaker, so I will state the question, and if you wish to respond, you're welcome to do so. You're up at the podium, or I can have the microphone here. So how can 106 guarantee that if enacted, it will not affect the life insurance policy? Is that not a contract?
From my position, it is a contract. And although that was not anything that I had time to go through in my answers, I do think that there's a problem with that. It isn't clear exactly how it would affect an insurance policy.
And as a reminder, respondents have 1 minute to answer the question.
Yes. Insurance companies specifically cannot deny payment related to, if they have a policy, whether it be an annuity, a health or a life insurance policy, they cannot deny payment if an individual chooses to utilize the aid and dying law. The cause of death, as we mentioned before, is the underlying illness. The cause of death specifically is not the self-administered medications. So that is a protection. And there are people who have annuities, who have situations that there's a concern on the part that should they use this particular situation, their life insurance would be voided. That's not the case.
Thank you. Another question on Prop 106. What are the differences in the Colorado and Oregon laws? The differences in the Colorado and Oregon laws that either of you like to pick up?
All I'll mention is that the Colorado laws and Oregon laws are, again, very, very similar. There are some specific protections that have been added in the Colorado law. But if you take a look at the Oregon law and take a look at the major provisions and the protections, Colorado's law was based upon that. I don't have, off the top of my head, all those, there are a few additional elements that have been added. But that's one of the reasons that when the folks got together to produce the Colorado law, they looked at Oregon, they looked at that 18-year history, they looked at the fact that there were cases, there weren't abuses, and modeled the law specifically after the provisions.
My earlier comments, I think I tried to speak to some of that. From the point of view of people who have looked at the law, it seems like the Colorado measure is not as rigorous as the Oregon law or the Washington.
We'll stick with 106. In the event that a terminally ill patient does not at first find two physicians in agreement, can he keep looking until he finds two who agree?
Yes, the answer to that question is yes. The provisions of the law specifically state two physicians. So just like any situation where a patient would be unhappy with the care that they're receiving for whatever reason, it doesn't specifically have to be end-of-life issues, but people are obviously free to choose physicians that they feel are meeting their particular needs. So the answer to that question is yes.
I tried to speak to this, I think actually earlier also. Part of the problem that those who are against the measure have is that, yes, it is two physicians or a physician and someone consulting. The issue is that it's not clear exactly which physician it would be. And since it comes from the patient's point of view, it could be just about anyone. Is it the question then becomes, is it appropriate to have, say, one kind of physician who, I'll give the example of, say, a podiatrist, who would sign off on, ovarian cancer, for example. We see that as one of the weaknesses of the law.
If the patient decides to not go through with the procedure, can he keep the medication?
It's an interesting theoretical question. The first time I've heard that one. I would hope that the physician involved in the situation would be monitoring that with the patient and would have the professional responsibility to have that taken care of.
That's a great question. I think actually that's one of the sort of general issues about the proposition, that there are things that are not covered in this. The answer for me would be, who knows? And that's part of the problem. None of that is spelled out. And that may be a detriment within the proposition. In other words, given how serious this is, should we make sure that all our T's are crossed, all our I's are dotted before we go in this direction?
Well, actually, it is spelled out. It says right here in the measure what has to happen with it if they decide not to use or if it remains unused. There are two options.
106 again. Does 106 provide spiritual, religious, philosophical aid in the process?
The answer specifically is no. At that point, it's again the discussion between the attending physician, the patient, and the responsibility that the physician has to meet the patient's needs, as they would related to any other medical care that they're receiving on an ongoing basis. But there is no specific requirement that there be any quote-unquote spiritual counseling for an individual to utilize what Proposition 106.
Yes, I would agree with that actually as well, with the additional comment that given the fact that in our country there is a division between church and state, we would want that in that bill anyway. It would be the individual, it would be up to the individual to find that kind of comfort.
106, two final questions for 106. First one, who monitors the actual consumption of the medication?
There is no requirement for monitoring. As we mentioned, the physician is not required to be present. And in situations which have occurred in Oregon, the family and loved ones specifically did not want a medical professional there. They felt it was a situation that they wanted family members and the patient who took the medication. It's really pretty much up to them to decide the circumstances of how that occurs. And no, there is no requirement for anybody to quote unquote monitor, nor for a physician or a medical professional to be present.
I would agree with that, and that is again, from my point of view, one of the weaknesses within the proposition. I mentioned that in Washington and Oregon, they tended to use barbiturates, a cocktail of some 100 pills that once you take it, it sometimes looks like oatmeal or like a yogurt, and you've got to be able to take it very quickly and consume it. It can lead to extreme gasping and muscle spasms, vomiting, and sometimes inhaling the vomit. It is not always a clean and simple death. And the fact that it is in the hands of the individual and there is no physician, I think is actually one of the
Okay, final question, it stays on 106. In which ways is the Colorado law less rigorous than the Oregon law?
Some of the ways that I mentioned before is, for example, about the two physicians. The proposition's language is inexact. The certifying or consulting physicians could be of any sort. And again, I made the suggestion that you could have one type of physician, like a podiatrist, sign off on death because a patient is terminal with stomach cancer. One of the other issues is in terms of mental health. Needing to have a mental health professional work more closely with the individual, especially because depression is something that could possibly be worked through. It's important to have that person there. The Oregon and Washington laws are stronger on that.
I just need to address the issue about this theoretical podiatrist who is diagnosing cancer. Having worked in hospitals for a number of years, you are never going to have a practical situation in which a podiatrist is going to be involved in a cancer death of a woman who has cervical cancer. So let's get practical from that particular standpoint. That's an interesting theory, which in practical medicine has no basis whatsoever. As far as the Oregon law, again, I took a look at some of my notes. I'm surprised I don't have that. But if you go on the website at Compassion and Choices, there's some specific information about the additions that were made to the Colorado law from Oregon. We're not talking about anything that was substantial related to the medications or the certifications or that type of thing. There was some specific requirements for documentation. There are some differences in terms of documentation that physicians would submit to the state health department in some cases. But as far as the actual nuts and bolts of the law, there's really no major difference.